What are the cutaneous manifestations of diabetes mellitus and how do they relate to glucose control? Answer: diabetes mellitus has several notable cutaneous manifestations, including diabetic dermopathy, necrobiosis lipoidica, and acanthosis nigricans. Diabetic dermopathy, characterized by trophic, hyperpigmented macules on the shins. This condition is related to microangiopathy and is often asymptomatic. Necrobiosis lipoidica, present as well-defined, shiny, yellow-brown plaques, usually on the shins, and can be symptomatic. It is thought to be related to collagen degeneration and is more common in patients with poorly controlled diabetes. Acanthosis nigricans appears as velvety thickening of the skin, primarily in body folds, and is associated with insulin resistance. It is a marker for metabolic syndrome. Impact of glucose control. Effective glucose control is crucial for preventing and managing these dermatologic conditions. Poor glycemic control can worsen skin manifestations and delay wound healing due to impaired vascular function and immune response. Guidelines recommend regular monitoring of HbAC levels to evaluate long-term glucose control. Discuss the diagnostic approach for amyloidosis with cutaneous manifestations. Include specific biopsy findings. Answer: amyloidosis can present with various cutaneous manifestations, including macular and nodular lesions. The diagnostic approach includes clinical evaluation, identifying skin changes such as purpura, nodules, or waxy papules, which may suggest systemic involvement. Biopsy: a punch biopsy of the skin lesion is performed. Histological examination typically reveals amorphous eosinophilic deposits in the dermis. Congo red staining. This is crucial. A positive staining under polarized light demonstrates apple-green bifringence, confirming amyloid deposits. Systemic evaluation. It is essential to assess for systemic involvement, including organ function tests and imaging studies, especially in suspected primary amyloidosis, which is associated with plasma cell dyscrasia. Treatment options. Management depends on the type of amyloidosis and may include systemic therapies like chemotherapy for AL amyloidosis or supportive care for secondary types. Explain the cutaneous manifestations and management strategies for patients with lupus erythematosus. Answer: lupus erythematosus can manifest in different forms: discoid, subacute cutaneous, and systemic lupus erythematosus. SLE, discoid lupus, presents as erythematous plaques with adherent scale and can lead to scarring. Management includes topical corticosteroids, calcineurin inhibitors, and systemic therapies for extensive disease. Subacute cutaneous lupus, characterized by annular or papulosquamous lesions, typically triggered by sun exposure. Treatment involves photoprotection, topical corticosteroids, and antimalarial drugs like hydroxychloroquine. Systemic lupus erythematosus can present with various cutaneous signs, including the classic butterfly rash. Management focuses on systemic immunosuppressants, e.g., corticosteroids, methotrexate, and strict sun protection due to photosensitivity. Guidelines. According to the American Academy of Dermatology, it is essential to monitor for systemic involvement and adjust treatment based on disease activity and response. Mr. Smith is a 55-year-old male recently diagnosed with chronic kidney disease, CKD. He presents with severe pruritus and dry skin. What underlying mechanisms might explain these cutaneous changes, and what management strategies could you recommend to alleviate his symptoms? Answer: Mr. Smith's symptoms can be attributed to several mechanisms associated with CKD. Uremic pruritus. This common symptom in CKD patients is believed to be due to the accumulation of uremic toxins affecting skin nerve endings, as well as imbalances in calcium and phosphate metabolism. Dry skin xerosis. Patients often experience reduced skin hydration due to the inability to maintain moisture, exacerbated by diuretic therapy and environmental factors. Management strategies. Moisturizers. Regular use of emollients can significantly help improve skin hydration. Antihistamines. These can be effective for managing pruritus, although they may not address the underlying cause. Phototherapy. In severe cases, narrowband UVB therapy may be considered. Dialysis consideration. Ensuring adequate dialysis can reduce the buildup of toxins contributing to pruritus. What is the relationship between thyroid disorders and dermatologic conditions such as vitiligo and alopecia areata? Answer: thyroid disorders, particularly autoimmune conditions like Graves' disease and Hashimoto's thyroiditis, can significantly influence skin health. Vitiligo. This is often associated with autoimmune thyroid disease, particularly Hashimoto's. The pathophysiology involves autoimmune destruction of melanocytes, leading to loss of skin pigmentation. Alopecia areata. This condition, characterized by hair loss, can also occur in individuals with autoimmune thyroid disease due to shared immune pathways. Studies show an increased prevalence of thyroid antibodies in patients with alopecia areata. Management. Addressing the underlying thyroid dysfunction is critical. Treatments may include corticosteroids for vitiligo and topical immunotherapy for alopecia areata. Regular monitoring of thyroid function is recommended as optimal thyroid hormone levels may help stabilize skin manifestations. Describe the cutaneous manifestations of chronic liver disease and their implications for patient management. Answer: chronic liver disease can present various cutaneous manifestations, including jaundice, yellowing of the skin, and sclera indicates elevated bilirubin levels. Spider angiomas. These vascular lesions are a result of estrogen imbalance and increased blood flow in hepatic cirrhosis. Pomererythema, often associated with increased blood flow due to liver dysfunction. Pruritus. This symptom arises from bile salt accumulation and can be particularly distressing. Management implications. Identifying the cause of liver disease is essential for treatment. For symptomatic relief, cholestyramine can be prescribed to alleviate pruritus. Additionally, patients should be educated about the potential for skin infections and the importance of sun protection, as patients with liver disease may be more susceptible to skin damage. What is the significance of cutaneous porphyrias and how are they diagnosed and treated? Answer: cutaneous porphyrias, such as porphyria cutanea, Toda PCT, and erythropoietic protoporphyria, are characterized by photosensitivity and blistering skin lesions upon sun exposure. Diagnosis: clinical examination, identification of blistering lesions typically on sun-exposed areas. Laboratory tests, measuring porphyrins in urine, plasma, or feces at elevated levels of uroporphyrin in PCT are diagnostic. Treatment: phlebotomy. In cases of PCT, periodic phlebotomy can reduce iron overload and decrease porphyrin levels. Hydroxychloroquine. This medication can be effective in managing skin symptoms, particularly in PP. Sun protection. Strong sun protection measures are crucial to prevent skin damage. Guidelines suggest regular follow-ups and monitoring of liver function, as porphyrias can be associated with liver disease. How does systemic sclerosis scleroderma manifest cutaneously, and what are the treatment options? Answer: systemic sclerosis or scleroderma presents with significant cutaneous manifestations including sclerodactyly, thickening and tightening of the skin on the fingers leading to decreased mobility. Digital ulcers, these can occur due to vascular changes and are often painful. Calcinosis, the formation of calcium deposits in the skin can cause discomfort and cosmetic concerns. Treatment options: symptomatic management. Topical treatments like moisturizers and corticosteroids can help with skin thickening. Immunosuppressants. Agents such as methotrexate or mycophenolate mofetil may be used for systemic involvement. Raynaud's phenomenon management. Calcium channel blockers can be effective in treating digital ischemia. Identify the key differences in skin manifestations between Crohn's disease and ulcerative colitis. Answer: both Crohn's disease and ulcerative colitis are kind of cutaneous manifestations, but they differ significantly. Crohn's disease, pyoderma gangrenosum, characterized by painful necrotic ulcers often associated with active disease. Erythema nodosum, presents as painful erythematous nodules on the lower legs. Ulcerative colitis, mucosal involvement, primarily affects the colon and may lead to skin changes like pyoderma gangrenosum as well, but typically does not present with erythema nodosum as frequently as Crohn's. Management. Treatment involves controlling the underlying bowel disease, often utilizing corticosteroids, immunosuppressants, and ensuring comprehensive skin care to manage lesions effectively. Regular dermatologic evaluations are recommended to monitor skin health. Discuss the implications of hyperlipidemia in dermatology, particularly the role of cutaneous markers. Answer: hyperlipidemia can have significant dermatological implications, with cutaneous markers often serving as indicators of underlying lipid disorders. Xanthomas. These can present in various forms, e.g., eruptive tuberous tendon, and are indicative of dyslipidemia. Their presence warrants further lipid profiling. Diagnosis: a thorough clinical evaluation and lipid panel are essential. Eruptive xanthomas often correlate with very high triglyceride levels, 1000 mg/dl. Management: treating the underlying lipid disorder through dietary changes. Statins or other lipid-lowering therapies can lead to regression of xanthomas. Guidelines recommend regular monitoring of lipid levels and management of cardiovascular risk factors. Explain the pharmacodynamics of topical corticosteroids, including their mechanism of action, classification by potency, and the specific side effects associated with their prolonged use. Additionally, discuss the recommended guidelines for their application to different anatomical areas. Answer: topical corticosteroids exert their therapeutic effects primarily through the inhibition of the inflammatory response by binding to cytoplasmic glucocorticoid receptors. This results in decreased production of inflammatory mediators, including cytokines and chemokines. They are classified into 4 categories based on potency: low E, G hydrocortisone medium E, G triamcinolone high E, G beta-methasone dipropionate and superpotent E, G clopidogrel. Side effects of prolonged use include skin atrophy, striae, telangiectasia, and possible systemic absorption leading to adrenal suppression, particularly when applied to occluded areas or in high-potency formulations. Guidelines for application recommend using low-potency steroids for sensitive areas like the face and intertriginous regions, while higher-potency agents can be used on thicker skin such as the palms and soles. The frequency of application should typically be twice daily, and it's advised to use corticosteroids for the shortest duration necessary to achieve the desired effect. Discuss the mechanism of action of commonly used topical antibiotics in dermatology. How do these agents contribute to the management of conditions like acne, and what considerations should be taken into account regarding bacterial resistance? Answer: topical antibiotics such as mupirocin, clindamycin, and erythromycin work by inhibiting bacterial protein synthesis, specifically through binding to the 50 subunit of the bacterial ribosome. Mupirocin is particularly effective against Staphylococcus aureus, including methicillin-resistant strains, making it valuable for treating impetigo and skin infections. In acne management, clindamycin and erythromycin reduce the population of Propionibacterium acnes, which is implicated in inflammatory acne lesions. Considerations regarding bacterial resistance include the risk of developing resistance to these antibiotics with prolonged use. It is recommended to combine topical antibiotics with benzoyl peroxide to mitigate resistance development while enhancing treatment efficacy. Additionally, rotation or cycling of topical agents can help preserve their effectiveness over time. Identify the immunosuppressive agents commonly used in dermatology, detailing their mechanisms of action and key monitoring parameters. Discuss the implications of using these agents in the context of pregnancy and potential risks for liver toxicity. Answer: common immunosuppressive agents used in dermatology include methotrexate, cyclosporine, and mycophenolate mofetil. Methotrexate works by inhibiting dihydrofolate reductase, leading to decreased DNA synthesis and cell proliferation. It is effective in conditions like psoriasis and severe dermatitis. Key monitoring parameters include liver function tests, complete blood counts, and renal function, as it can cause hepatotoxicity and bone marrow suppression. Cyclosporine inhibits T-cell activation by blocking calcineurin, which is crucial for interleukin-2 production. Monitoring should include blood pressure, renal function, and serum electrolytes, as it can cause nephrotoxicity and hypertension. Mycophenolate mofetil inhibits purine synthesis and is utilized for conditions such as pemphigus. Monitoring involves assessing for signs of infection, as it significantly increases susceptibility due to its immunosuppressive effects. Pregnancy considerations. Methotrexate is contraindicated due to its teratogenic effects, while cyclosporine and mycophenolate mofetil require careful risk assessment. Pregnant patients should undergo rigorous monitoring and counseling regarding potential risks to fetal development. MS. Anderson, a 45-year-old woman with severe plaque psoriasis, is considering treatment options. She has a history of latent tuberculosis (TB) and is concerned about the risks associated with biologics. What considerations should be taken into account when determining her eligibility for biologic therapy, and what pre-treatment evaluations are necessary? Answer: when considering biologic therapy for MS, Anderson, it is essential to evaluate her history of latent TB, as biologics such as TNF inhibitors e.g. ethanoset adalimumab can increase the risk of reactivation. Key considerations include screening for TB. A thorough assessment should involve a tuberculin skin test (TST) or an interferon gamma release assay (IGRA) to evaluate for latent TB infection. If positive, she should undergo treatment for latent TB before starting biologic therapy. Comorbidities. Assess for other comorbid conditions that may contraindicate specific biologics, such as chronic infections, malignancies, or significant heart failure. Monitoring. Once on therapy, MS. Anderson should be monitored for signs of TB reactivation and other infections. Regular follow-ups should include complete blood counts, liver function tests, and assessments for allergic reactions. Patient counseling. Discuss the benefits versus risks of biologics, emphasizing the importance of adherence to screening protocols and prompt reporting of any signs of infection. Describe the mechanism of action of systemic retinoids, including isotretinoin and acitretin. Discuss the specific monitoring requirements, particularly focusing on lipid abnormalities and teratogenicity precautions. Answer: Systemic retinoids, such as isotretinoin and acitretin, function by modulating gene expression related to cellular proliferation and differentiation. They exert anti-inflammatory effects, reduce sebum production, and normalize keratinization in the sebaceous glands, making them effective for severe acne and psoriasis. Monitoring requirements include lipid abnormalities. Isotretinoin can cause significant elevations in triglycerides and cholesterol levels, therefore, baseline and periodic lipid panels are necessary during therapy. If triglyceride levels exceed 500 mdL, isotretinoin should be discontinued or the dosage adjusted. Teratogenicity. Isotretinoin is highly teratogenic, requiring strict adherence to the iPledge program, which mandates pregnancy prevention measures, including 2 forms of contraception prior to and during treatment. Monthly pregnancy tests are required during therapy, and patients must be educated about the risks and the importance of complying with these precautions. Explain the role of topical antivirals, particularly acyclovir and penciclovir, in the treatment of herpes simplex virus (HSV) infections. Discuss the efficacy, dosing considerations, and factors that influence their clinical use. Answer: topical antivirals like acyclovir and penciclovir are effective in managing HSV infections, particularly for reducing the duration and severity of lesions during outbreaks. Mechanism of action. Both agents inhibit viral DNA synthesis by selectively targeting the viral thymidine kinase enzyme, which phosphorylates the drug, leading to chain termination. Efficacy. Clinical trials have demonstrated that these agents can significantly reduce healing time and duration of pain when applied early in the course of an outbreak. Dosing considerations include applying acyclovir 5 times daily for 5-10 days at the onset of symptoms, while penciclovir is applied every 2 hours during waking hours for up to 4 days. Factors influencing clinical use include the frequency of outbreaks, patient compliance with application, and potential side effects like localized irritation. In cases of frequent recurrences, oral antivirals may be more appropriate. Compare and contrast the mechanisms of action and indications for oral antibiotics and hormonal therapies in the treatment of inflammatory acne. What are the potential side effects of each class of medication? Answer: oral antibiotics, such as doxycycline and minocycline, primarily function by reducing inflammation and inhibiting the growth of Propionibacterium acnes. They are indicated for moderate to severe inflammatory acne. Side effects may include photosensitivity, gastrointestinal disturbances, and potential for drug resistance with prolonged use. Hormonal therapies, such as spironolactone, work by antagonizing androgen receptors, thereby decreasing sebum production. They are particularly effective in females with hormonal acne and are often used in conjunction with oral contraceptives for added efficacy. Side effects of spironolactone may include hyperkalemia, menstrual irregularities, and breast tenderness. Combining these therapies can enhance treatment efficacy while addressing different aspects of acne pathophysiology. Monitoring for side effects is essential, particularly with hormonal therapies. Discuss the pharmacodynamics of topical antifungal agents, such as azoles and allylamines, in treating dermatophyte infections. What are their mechanisms of action, and what monitoring should be performed for systemic antifungal therapies? Answer: topical antifungal agents like azoles, e.g. clotrimazole, ketoconazole, and allylamines, e.g. terbinafine, naphthafine, work by inhibiting ergosterol synthesis, an essential component of fungal cell membranes. Azoles inhibit the enzyme lanosterol demethylase, while allylamines block squalene epoxidase. Monitoring for systemic antifungal therapies, e.g. itraconazole, fluconazole, should focus on liver function tests, as these agents can cause hepatotoxicity. In addition, serum levels may be monitored for itraconazole to ensure therapeutic dosing, particularly in immunocompromised patients or those with extensive infections. Overall, the choice between topical and systemic antifungals depends on the severity and extent of the infection, with topical agents being sufficient for localized infections and systemic therapies reserved for more widespread or refractory cases. Outline the current management strategies for moderate to severe psoriasis, including systemic therapies, biologics, and phototherapy. Discuss the rationale for using combination therapy and the importance of patient education in treatment adherence. Answer: management strategies for moderate to severe psoriasis may include systemic therapies, e.g. methotrexate, cyclosporine, biologics, e.g. TNF inhibitors, IL-17 inhibitors, and phototherapy, e.g. narrowband UVB, PUVA. Combination therapy rationale. Combining therapies can enhance effectiveness by targeting different aspects of psoriasis pathophysiology, minimizing side effects by using lower doses of each agent, and providing more comprehensive management of the disease. Patient education is critical in treatment adherence. Patients should be informed about the chronic nature of psoriasis, the importance of lifestyle modifications, e.g., avoiding triggers, maintaining a healthy weight, and the potential side effects of medications. Educating patients about the treatment goals and the expected timeline for results can improve compliance and overall treatment outcomes. Identify the key risk factors for non-melanoma skin cancers, SES, and melanoma. Discuss preventive measures that should be implemented, including public health strategies and individual patient education. Answer: key risk factors for NMSCS, e.g., basal cell carcinoma, squamous cell carcinoma include chronic UV exposure, fair skin, history of sunburns, older age, and immunosuppression. For melanoma, risk factors encompass family history, atypical moles, high UV exposure, and personal history of skin cancer. Preventive measures include public health strategies, promoting sun safety through community education campaigns, implementing school-based sun safety programs, and enforcing policies regarding sunscreen use in public areas. Individual patient education, advising patients to use broad-spectrum sunscreen with SPF 30, wear protective clothing, and seek shade during peak sun hours. Regular skin self-examinations and dermatological evaluations are essential for early detection. Overall, a comprehensive approach to prevention involves both individual responsibility and broader community efforts to reduce the incidence of skin cancers. What are the primary considerations for choosing between shave, punch, and excisional biopsies for a suspected melanoma lesion? Answer: when choosing a biopsy technique for a suspected melanoma lesion, factors include lesion depth, size, location, and suspicion level. For melanoma, shave biopsy best for superficial lesions as it removes only the epidermis and part of the dermis. However, shave biopsies are generally discouraged for suspected melanoma due to the risk of incomplete depth assessment. Punch biopsy, useful for smaller lesions less than 6 millimeters and provides a full thickness sample. It is suitable for moderately deep lesions but may miss the full margins if the lesion is larger. Excisional biopsy, preferred for suspected melanomas as it removes the entire lesion with a margin, allowing for comprehensive pathology analysis. This biopsy method is crucial for accurate staging and ensuring clear margins. The American Academy of Dermatology guidelines suggest excisional biopsy with a 1-2 mm margin for all suspected melanomas to ensure an accurate diagnosis and margin assessment. Ms. Lee, a 45-year-old woman, has received a botulinum toxin injection to address forehead wrinkles. However, 2 days post-treatment, she experiences ptosis, drooping of the eyelid on her left side. What should Ms. Lee's dermatologist do to manage this complication? Answer: ptosis is a known but rare complication of botulinum toxin injections due to diffusion of the toxin to the levator palpebrae superioris muscle. Management steps include reassurance and explanation. Inform Ms. Lee that ptosis is typically temporary and may resolve within 2-4 weeks as the toxin effects wear off. Use of alpha-adrenergic agonists. Prescribe upropionidine 0.5% eye drops, which can stimulate Muller's muscle, temporarily lifting the eyelid by 1-2 millimeters. Avoid additional toxin injections. Further injections should be avoided until the ptosis resolves. The American Society for Dermatologic Surgery guidelines recommend a conservative approach to managing botulinum toxin complications with minimal intervention and reassurance as the first line. Explain the key safety protocols a dermatologist must follow when performing ablative laser therapy for acne scar treatment. Answer: safety protocols for ablative laser therapy include patient evaluation, assess skin type, scarring depth, and medical history, e.g., susceptibility to keloids or photosensitivity, eye protection. Both patient and staff must wear appropriate protective eyewear that blocks the specific wavelength of the laser. Skin cooling and anesthesia. Cooling devices prevent thermal damage to surrounding tissues, and topical or local anesthesia reduces pain and inflammation. Controlled settings. Set the laser energy level and pulse duration precisely to minimize unwanted damage to surrounding tissue. Post-treatment care. Advise on wound care, sun protection, and signs of infection or excessive scarring. Following these guidelines aligns with FDA standards and OSHA regulations to ensure patient and practitioner safety during laser procedures. Why is it essential to follow standardized surgical margins when excising basal cell carcinoma, and what are the recommended margins based on lesion type? Answer: surgical margins are critical in excising basal cell carcinoma (BCC) and ensuring complete tumor removal while minimizing recurrence. The primary rationale for following standardized surgical margins lies in the biology of skin cancer. BCC often extends beyond its clinical boundaries, making it essential to excise adequate surrounding tissue. For low-risk EECS, such as superficial or nodular types located in non-critical areas, a 4 mm margin is generally sufficient. This margin allows for the removal of potential microscopic extensions of the tumor while preserving healthy tissue. Conversely, high-risk lesions, which may include aggressive subtypes like infiltrative or morphiform BCC or those occurring in cosmetically sensitive regions e.g., the nose or eyelids, necessitate wider margins of 5 to 10 mm. The increased margin reduces the likelihood of recurrence significantly. Following the National Comprehensive Cancer Network (SEN) guidelines, which recommend margins based on tumor type and location, is crucial. These guidelines help ensure that clinicians adhere to best practices based on evidence and expert consensus. Additionally, assessing the histopathological characteristics of the tumor post-excision is vital for determining if further surgical intervention is necessary. What are the indications for Mohs micrographic surgery, and why is it considered superior for certain skin cancers? Discuss the mechanisms of narrowband UVB therapy in the treatment of psoriasis and its advantage over broadband UVB. Mr. Grant, a patient with Fitzpatrick skin type IV, receives an IPL intense pulsed light treatment for pigmentation issues. After treatment, he experiences hyperpigmentation. What should the dermatologist consider in future treatments, and what could be the reason for this complication? Answer: hyperpigmentation following intense pulse light IPL treatment is a recognized complication, particularly in patients with Fitzpatrick skin types Roman have higher melanin content. In Mr. Grant's case, his post-treatment hyperpigmentation can be attributed to excessive melanin production triggered by the IPL's energy absorption. This phenomenon is exacerbated in darker skin types, which are more susceptible to post-inflammatory hyperpigmentation due to the laser's effect on the melanocytes. To mitigate risks in future treatments, the dermatologist should consider alternative options better suited for darker skin. ND laser, for instance, penetrates deeper and has a longer wavelength, reducing the likelihood of superficial pigmentary changes. It is crucial to implement a patch test prior to full treatment, allowing for an assessment of skin response to the laser and adjustment of parameters as necessary. Additionally, employing lower energy settings and extending the intervals between sessions can help reduce the risk of complications. Pre-treatment with topical agents like hydroquinone or retinoids can help inhibit melanin synthesis and prepare the skin for treatment, decreasing the likelihood of hyperpigmentation. What are the risks associated with performing a deep chemical peel on Fitzpatrick skin type V, and how can these risks be mitigated? Answer: deep chemical peels, typically using agents like phenyl or trichloroacetic acid, pose significant risks for patients with Fitzpatrick skin type V and VI due to their heightened susceptibility to complications such as post-inflammatory hyperpigmentation, PE, and scarring. The intense exfoliation and skin penetration involved in deep peels can provoke an overreaction in the melanin-producing cells, leading to uneven pigmentation following healing. To mitigate these risks, dermatologists should carefully evaluate the patient's skin type and history before proceeding. For patients with darker skin types, a superficial or medium-depth peel, such as glycolic acid or salicylic acid, may be more appropriate. These peels offer benefits such as improved skin texture and tone with a low risk of adverse effects. Pre-treatment strategies are also essential. Using agents like hydroquinone or retinoids for several weeks before the peel can help prepare the skin by reducing melanocyte activity, thus lowering the risk of PIH. Post-treatment care is equally important. Patients should be instructed to adhere to strict photoprotection measures, using broad-spectrum sunscreen and avoiding direct sunlight for several weeks post-peel. Additionally, recommending gentle skincare products during the healing process can further minimize irritation and pigmentation changes. Following the American Academy of Dermatology guidelines on patient selection and post-procedure care is crucial in providing safe and effective treatment while maintaining optimal cosmetic outcomes for patients with darker skin types. Identify and explain the most serious complication associated with dermal filler injections, particularly in the glabellar region, and how it can be managed. Answer: the most serious complication associated with dermal filler injections, particularly in the glabellar region, is vascular occlusion. This occurs when the filler enters a blood vessel, potentially leading to tissue ischemia, necrosis, or in severe cases, blindness, particularly if the filler reaches the ophthalmic artery. Management of vascular occlusion requires immediate action. The first step is to aspirate the syringe to determine if blood is present, which indicates vascular entry. If blood is aspirated or there is suspicion of occlusion, the clinician should immediately inject hyaluronidase if the filler is hyaluronic acid based, as this enzyme can dissolve the filler and restore blood flow to the affected area. Following hyaluronidase injection, applying warm compresses to the area can promote blood flow and alleviate discomfort. In some cases, additional treatments such as oral aspirin or topical nitroglycerin may be beneficial to assist in vasodilation and improve blood supply. The FDA emphasizes the importance of adhering to safety protocols during filler injections, including thorough anatomical knowledge of vascular structures and the use of appropriate injection techniques to minimize risks. Furthermore, the American Society for Dermatologic Surgery recommends ensuring that practitioners are well trained in managing complications and aware of the symptoms of vascular occlusion. Effective patient education about the risks and early signs of complications is also crucial in improving outcomes and enhancing patient safety during cosmetic procedures. Why is patient education on light exposure critical after photodynamic therapy (PDT), and what guidelines should be followed? Answer: patient education on light exposure following photodynamic therapy (PDT) is paramount due to the heightened photosensitivity induced by the treatment. PDT involves applying a photosensitizing agent to the skin, which is activated by specific wavelengths of light. This process can lead to increased susceptibility to sunburn and other adverse effects if the patient is exposed to light sources post-treatment. To mitigate risks, patients should be informed to avoid direct sunlight for at least 48 hours after treatment. During this period, their skin is more reactive and exposure can result in severe burns, blistering, and prolonged erythema. Patients should also be advised to wear broad-spectrum sunscreen with an SPF of 30 or higher and protective clothing to shield treated areas from UV radiation. In addition to sunlight, patients should avoid artificial light sources that emit UVA, such as certain indoor lighting and tanning beds, as these can also trigger photosensitive reactions. Following the FDA and American Academy of Dermatology guidelines on post-ET care is crucial. These guidelines emphasize the importance of thorough patient education about the risks associated with photosensitization and the necessary precautions to take following treatment. A patient experiences sudden pain and skin discoloration after receiving dermal fillers, indicating possible vascular occlusion. What immediate steps should the clinician take, and what practices can be implemented to minimize such risks in injectable treatments? Answer: safety protocols in dermatology, particularly concerning injectable treatments like dermal fillers, are critical for minimizing risks and ensuring patient safety. One of the primary complications associated with dermal fillers is vascular occlusion, which can occur when the filler inadvertently enters a blood vessel during injection. This serious complication can lead to significant adverse outcomes, including tissue ischemia or even blindness. To mitigate such risks, dermatologists must adhere to specific safety protocols. Firstly, thorough anatomical knowledge of the facial vasculature is essential. Understanding the location of major blood vessels can help practitioners avoid intravascular injection. Secondly, using appropriate injection techniques is crucial. Slower injection speeds, the use of cannulas instead of needles, and aspiration before injection can significantly reduce the risk of vascular occlusion. The FDA and American Society for Dermatologic Surgery have established guidelines that emphasize the importance of training and education in recognizing and managing complications effectively. Furthermore, educating patients about the potential risks and signs of complications empowers them to seek prompt treatment if necessary.